With that, I'm going to turn it over to Secretary of Health Dan Carey, who will kick off this presentation. Thanks so much.
All right, thank you, Elena, and good afternoon. As Elena indicated, I'm Dan Carey, Virginia's Secretary of Health and Human Resources, and we're hoping today we'll have a informative discussion and briefing on models that we will be looking at for the COVID-19 response here in Virginia. From the beginning, Governor Northam has made it clear that everything we do must be grounded in science, public health expertise, and data. And while the data is incredibly complicated and no model is perfect, and as you'll see today, these models are not perfect, we are proud to be working with some of the top minds in the country on these projections and modeling of the COVID-19 pandemic in the US as well as here in Virginia. And it is also important to remember this is not a crystal ball, and these models change every single day, and the indications and predictions that are made from these models change, sometimes subtly and sometimes dramatically. Again, there are no perfect predictors when it comes to this rapidly changing situation. But we use these different models to help inform a range of outcomes that we may be facing so we can make sure that Virginia is prepared for all possible scenarios. So with that in mind, I'd like to quickly go over our run of show, our agenda today. First, we will hear from Carter Price from the RAND Corporation, who will share their overview of modeling and projections. Next, we will welcome the team from the UVA Biocomplexity Institute, Chris Barrett, Madhav Maranthe, and Brian Lewis, to review the UVA model. And following both presentations, I will offer some brief closing remarks, and then we will open up for questions, and we'll need to close by 12:45. So to start, I'd like to welcome Carter Price from RAND. Carter, please go ahead.
Okay. Let's see, let me share the... Oh, wait, it's not letting me share. Here we go. One moment here. Okay. Okay, so yeah, today I will be discussing the models that Virginia is using to assess COVID-19. So our work so far, the models that we've primarily been reviewing thus far have been the University of Virginia model, Penn Medicine's CHIME model, and the University of Washington's IHME model. A few things to take note of here. First off, this analysis is preliminary. These models are being updated several times a week, and new data become available in some cases daily, and the initial data may be biased due to a lack of testing. And so these models will change as better data become available. And so that's something to take into account. I also note that the documentation for some of these models is better than others, and so we're able to glean more from some models about how they work and the mechanics of how they work. And we're going to continue to update and refine this work as new models, new data, and whatnot become available. So first off, I want to note sort of for the purposes that, what constitutes a suitable model? When should you trust one model over another? Because a lot of these models have different results. They're might say what appear to be contradictory things, and it's important to understand sort of what constitutes a suitable model. First off, we won't know how accurate any of these models are until after the fact. And in some cases, when they're used to compare different policy outcomes, we may never know. But models should behave in explainable ways. The policy changes should produce results that move in the direction that we expect, and then the magnitude of that response should be based on either data or analysis. And so it should map to what we expect to see based on historical events. However, I'll note that this is known as the novel coronavirus, and that's because it's novel. It's not something we've seen before, and so a lot of the data, they're just going to get better over time, and so that's something to be aware of. I also note that resource constraints are real, but there is an asymmetric risk when modeling COVID-19. And so if you can think about the decisions that are being made based off of these models, if you have one too many ICU beds or ventilators, that might cost a few $1,000s. On the other hand, if you have one too few, that's likely to cost lives. And so assumptions should be biased to reflect this concern. Now, the models that are used for this type of work typically fall into two categories. You'll have statistical models that are projections where you have empirical data, you fit curves or lines to that historical data, and then you might include some other controls such as the policy responses. And the IHME model is one example of this type of model. So that's a statistical model. There are also system dynamics models, and these are sometimes referred to as population models or theory-based models, but these are models that try and capture the way that the system works, the dynamics. And they typically assume an exponential growth in the number of infected. They rely on estimates of that rate of spread. And the UVA and CHIME model are both based on this, or fall into this category. They're of that type. So what are the advantages of the different modeling approaches? Systems, dynamics, and statistical models are both somewhat suitable when assessing how much of a threat a specific thing might be, sort of before the fact. The rate of spread is typically more suitable for analysis by a systems dynamics model than a statistical model. The extent of the spread, systems dynamics models are pretty good at that, but statistical models are typically not suitable for that type of analysis. The timing of the peak and the severity, again, these models are both sort of somewhat suitable for that, and it sort of depends really on the nuances of the model implementation as to whether one is preferable than the other. That's something to think about when comparing these different models, or when is one more advantageous, or when does the characteristics of one work better than others. So let's talk about the University of Pennsylvania's CHIME model. And so this is what's known as it's a systems dynamics model where people transition between the susceptible phase, where you are at risk of becoming infected, where you are infected, and then where after some point in time you have recovered from that infection. So that's why it's referred to as an SIR model. The population all starts off in the susceptible state, and then as the infection grows exponentially, people recover or die at some defined rate. Hospital beds and ICU utilization are then based on fixed ratios of the infected. Each infected person is modeled as infecting some number of people based on a rate that's typically the average rate of infections that stem from one case. Conceptually, these models do reflect a realistic spread for the early and middle phases of an epidemic, and so it's particularly useful in that phase of the analysis. These models are also very easy to implement and run, and so that's an advantage. However, because these models are simple, there are only a few ways that you can model policy responses. And so if you think about social distancing, there are the choices about how you think social distancing functions, how it works in practice, will lead to different results. And so if you think that social distancing lowers the rate of the spread, then that will will flatten the curve and push the timing of the peak forward in time. However, if you think that social distancing is more of a sequestration, where you take a segment of the population, and that segment of the population is not susceptible because they're not interacting with people outside in the general population, then that would lower the peak, but it would not move the peak forward. And so which of these results that you believe depends upon how you think the policy of social distancing works in practice. And in practice, it's likely somewhere in between, where some segment of the population is going to be sequestered and some segment will be just have reduced exposure. And so that's something to think about when looking at these models. The University of Virginia model, this is looks at the spread between, they use the patch sim model, which is similar to an SIR model. It's a variant that has has some extra capabilities, but some things that are particularly useful for for this model, that it does include the spread between geographic areas, and that's explicitly modeled based on travel data. And so that's very useful when looking at the early phase before people have started to change their behavior. The disease dynamics inside this, as I said, are modeled using a variant of SIR that allows for a lag between the exposure and the onset of infection, so people can be spreading this asymptomatically. And there are some other things that additional state allows you to capture. Additionally, this model has been calibrated based on actual flu data and flu spread to help sort of refine how these kinds of things work in practice. It uses county level data. So one advantage of this is it uses county level data for very detailed projections, and the calibration step means that this work is better tuned for looking at different regions. This model is also somewhat sensitive to the policy choices about how you think that a policy would actually work in practice. And so it is sensitive to that also. The IHME model used by the University of Washington, developed by researchers at the University of Washington. This is a statistical model, and it's based off of the trajectory and the number of confirmed COVID-19 deaths, and then it projects that fitted model forward. Hospitalization rates and utilization of ICU beds, ventilators, those kinds of things are based off of a simulation from the death rate. And this is based on data that's not just for Virginia. They have estimates from data coming in from China, Italy, Washington State, and other areas. And so it uses a lot of different information there. One advantage of this model is that it is not an SIR, SEIR type model. It's not a systems dynamics model. So when you look at the numbers from this model, you can compare it to the numbers from an SIR model, and you're getting sort of an independent or a different perspective. And so if you're comparing just different SIR models, the differences are going to be due to assumptions, not because there's some different behavior going on. Whereas this will sort of capture and sort of provide a different perspective. However, this model is likely biased, but it should improve with better data. And specifically, it's likely biased because of the lack of testing. And then particularly in the early phases, and so that could bias the trends. And then if you don't believe the trends that are starting this off, then you're not going to believe the trends that sort of followed up. And so that's a concern with this type of model. I also note that the model results haven't been particularly stable. And some of that's because as they get new data, they're able to better refine their estimates. But it's going to take a while for this model to stabilize and the results from this model to stabilize. I also note that the policy interventions are all treated equally, and so they don't distinguish between, whether social distancing is more or less effective than everybody wearing a mask. And so that's a limitation, and this model is not appropriate for comparing policy interventions or assessing whether one policy might be preferable to another. So the key takeaways here, CHIME, this may push the peak too far in the future because of how they model some of the policies such as social distancing. The IHME model may have the peak too early and the resource requirements too low at the peak because of bias in the data. The UVA and IHME models should get more accurate in time as better data, more accurate data become available. And that's particularly because of the dearth of initial testing. Really is going to bias a lot of the initial estimates coming out of these models. And also something to think about is that many of the parameters that are used in these models come from data and studies from China or Italy, and that the degree to which you think that those populations are comparable will tell you sort of the degree to which you think that you should believe those parameters. I'll note that CHIME is probably best used as a decision support tool for hospital level utilization rather than as a forecast. I wouldn't, my recommendation is not to use that model as a forecast, but then to look more towards UVA and IHME for forecasting types of approaches. And I'll also note that a synthesis should produce more reliable results. When you take these different types of models and compare the results, you should get something better than strictly looking at one model. And I guess we're saving questions for later, but yeah.
All right, perfect, Carter. Thank you so much. Next up, we'll be hearing from the team at the UVA Biocomplexity Institute, Chris Madhav, and Brian. You have the floor.
Okay, so let me start and take just 30 seconds, and then Brian will do the presentation. I want to thank Governor and Secretary for inviting us for this session. A team of about 85 scientists at UVA and our partner institutions has been tracking and developing models since early January when the COVID-19 virus became a threat. And we've developed these models, and Brian's results today that he presents to you all will hopefully help us understand where things are going. After he's done, during the question answer session, 3 of us can take questions and answer them. Brian, go ahead.
Thanks, Madhav. I'm hoping everyone can see the screen. Sort of yell at me if not. I'm here to talk to you and dig a little deeper into the UVA model. Thanks a lot, Carter, for providing that good overview. We'll be going over the estimation of the impact of COVID-19 here in our Commonwealth. Just a little word about who we are. We're a team of researchers at the Biocomplexity Institute, University of Virginia. This is 85 or so researchers that we use big data and simulations to understand massively interactive systems. That can range from the biomolecular all the way up to public policy. And we've got about 20 years of experience in crafting and analyzing these infectious disease models to help support planning and response to pandemics like this. We've spent a lot of time doing influenza. We were involved in the federal response to the Ebola outbreak in West Africa, addressed Zika and many other diseases over time. So we've got a bunch of these models and experience with this kind of data to draw upon. I'm Brian Lewis, and you've already heard from Madhav, and Director Chris Barrett is also on the phone. A quick overview here is I'm going to try and help you better understand the impact of COVID-19 mitigations here in Virginia using our model. And the basic approach here is that we're going to calibrate an explanatory mechanistic model to observe cases. We're going to project infections through the end of the summer. Then we're going to consider a range of possible different mitigation effects in a couple of what-if scenarios. This is important to understand that a mechanistic model, as Carter sort of gave overview, these system dynamics models, we are baking in what the difference is when we do these different social distancing measures. And we have parameters that reflect actual things that occur in the disease rather than it being a simple statistical model. And that allows us to do these what-if scenarios. What if we can test better? What if we change the way that people are interacting with each other? You can use this model then to also generate outcomes ranging from the number of people who are ill through the confirmed cases and all the way ultimately to those who may succumb and die from this disease. And the structure of this model is also set up so that we can look at the geographic spread over time and do some estimates of healthcare burdens as a result. I also want to give a few takeaways before I start. Projecting future cases precisely is impossible and probably not fully necessary. Even without perfect projections, we can confidently draw a conclusion. Some of the conclusions I want to share today are that the current social distancing efforts seem to be working. Under these current conditions, Virginia as a whole will have sufficient medical resources for at least the next couple of months. And other thing that these models also show us is that lifting these social distancing restrictions too soon or without alternative ways to address and contain the infections may lead to a quick second wave of infections. And we're going to look into other efforts to look at the effectiveness of test, trace, and isolate policies, which are the kinds of things I think we can do now that we've bought ourselves some time to help drive this infection rates further down. And as everyone's already said before, the situation is changing rapidly, and these models will be updated regularly to reflect those changes. So I want to get into a little bit how we've configured this model and some of the data we've analyzed to inform it. As Carter mentioned, we're using a simulation engine we call PatchSim, which is developed by researchers here at our institute. Srini, who's on the phone, is the main architect of it. It is a meta-population model. That means that basically we take the entire population of Virginia and represent it as a variety of patches, in this case, the different counties and independent cities of Virginia. In those patches, population can interact with itself, but it also interacts with the other counties and cities, representing travel, work commute, and those kinds of things. Again, we're using an extended SEIR representation, which means we allow people to be susceptible, they become exposed, ultimately they become infectious. Those infectious people can create other infections, change other susceptibles to exposed, then ultimately they get removed or recovered and no longer participate in the transmission dynamic. This simulation engine also allows us to incorporate the two effects that Carter covered very nicely, both changes in the way the population interacts, the ones that typically flatten and push the curve back, but also that affect the actual disease dynamics and testing and treating kind of scenarios where you can shorten periods of times or lengthen them depending on the actions that are taking place. And again, this runs fast on high performance computers and is ideal for these kinds of calibration or optimization type studies. So to give you a little better picture, we're going to dig in a little bit to the weeds, if you can bear with me here, is that we're going to look at two key parameters that are really hard to observe in the real world. This is the reproductive number and the infectious period. We're going to let those vary a little bit around what are commonly estimated as in the literature. For reproductive number, we're using a range of 2.1 to 2.3. This reproductive number is this rate of infection that Carter was alluding to. And in essence, what it means is that for every infectious individual in the population, it will create 2.1 to 2.3 other infections. And so you can start to do the math in your head there. 1 becomes 2, 2 becomes 4, and so forth. You get that exponential growth. The infectious period is a period of time that someone remains infectious, the number of days typically. We're letting that range from 3.3 to 5. And this has an impact on the total number of infections that can occur in that overall peak. To get this model rolling, once we have this transmission core set up, we need to initially infect people. We've been using some VDH data to give us the timing and location of these initial infections. And the fact of the matter is we are not observing all the people in the population who become infected. So we're assuming a 15% detection rate. About 50% of people don't even exhibit severe symptoms or symptoms whatsoever. And so what we're doing is we're taking the time and the place of infection. So say there's one person that's been confirmed on March 1st. We go back in time and we place 7 different cases over a couple of days leading up to that, assuming that one of those would be the ones who becomes confirmed. Key part to all these scenarios I'm about to show the results to are the mitigation scenarios. They have different durations and intensities. We can't know what those intensities truly are, nor how long they're going to last. So we're resorting to exploring this through 5 different scenarios. Let me try and describe these scenarios. It gets a little confusing, so I'm going to have to use an analogy. So we have these 5 possible ways that the future can unfold for us. And we're going to assume that there's 2 different levels of intensity for the purposes of these projections. and 2 different durations. And we're going to add in 1 more that has no effect from social distancing for comparison's sake that we're going to call unmitigated. The start of social distancing in these scenarios is March 15th. This is from analyzing data, and I'll go into that in a slide or 2 later, where we observed a change in the growth rate. The duration is we are trying to play out what the possible futures might be. We're considering one where these mitigations are lifted on April 30th or lifted on June 10th. So now to the intensity of these mitigations. We're terming these slowing growth versus pausing growth. This is a difficult concept to grasp. Even amongst ourselves, we've had trouble settling on how to describe this. The slowing growth is one where the social distancing slows the growth, but it doesn't necessarily mean that new cases don't increase anymore. They do continue to increase. So if we had a weekly number of new infections of 1,000, that might become 2,000, then 3,000 in subsequent weeks under the slowing growth scenario. Pausing is a different concept here. This is where social distancing effectively pauses the growth. So we would stay at a steady state of new cases week over week. Day over day, you would see the same rough number of cases being reported. At the moment, it seems as though we are tracking the data that we have, the pausing scenario. So keep that in mind. And a good analogy here, if you're trying to think about it simply along this table here on the right, that the unmitigated growth is like if you've got your pedal to the metal on the accelerator and you're just accelerating out of control. The slowing growth is more like you've got your foot firmly on the accelerator. You're not moving it much. You aren't going crazy out of control, but you are still making the car move faster and faster and faster. The pausing is more like you are at a cruising speed and you've put on the cruise control. You're just saying steady state. I'm going to get there when I get there. Providing this look here to let you know that there's a lot of things going on under the hood, a lot of different parameters. A lot of these have been informed by the best guess scenario that's been circulated by the CDC and a team of other modelers that we've been participating on for several months in this COVID-19 response. They're detailed here. I don't want to spend too much more time on it, other than to say you can see the ranges of transmissibility, and you can also look at the durations and the proportions of folks who become hospitalized and ventilated and so forth. Calibration approach, I want to go over briefly, but it suffices to say that we have data that we've analyzed. We have a model that we then parameterize, as I've just shown. We then go through a calibration step. This calibration step is basically we take this model and we provided some ranges of transmissibility and this duration of infectiousness for it to search over, and it looks to see which settings fit best to the observed data. And so if you vary one shorter and one higher, you can fit it reasonably well. You can do the opposite. There's a lot of uncertainty in terms of this. We have a narrow band on these parameters, but we don't know exactly what those values are. This allows us to capture uncertainty in these projections, allows us to provide a range of results when we project them forward. So now we want to look at the impact of interventions. And a key part to that is estimating the effects of social distancing to date here in the Commonwealth. Now, if we look at some of the anonymized mobility data from places like Google and Cuebiq and other mobility aggregators, they're showing that Virginia has greatly reduced its activities. And that's a promising sign. Google's reporting changes of 40% roughly at retail, recreation, and workplaces, reductions compared to earlier this year. Same thing in grocery stores, having a 20% reduction in activity. Cuebiq is showing greater than 50% reduction of an average individual's mobility compared to the year average. So we're doing a great job. Unfortunately, PatchSim does not have a parameter where I can just plug these in exactly. So what we've done is we've looked at the VDH data, and we've looked at the number of cases and the growth in these cases over the past month or so. So this plot on the right, you're seeing a blue line that's jittering all over the place. These are the daily growth rates. And so if you look day over day on the cases being reported, you'll see things going up and down. There's a lot of reporting biases. You see lower case counts during the weekends because you just don't get as many confirmed cases over the weekend and so forth. And so what we've done is we've taken a weekly average from Sunday through Saturday, and that's reflected in this more steady orange line. If you look here in the middle, right around March 15th, we can see week over week, we see a reasonably sharp drop in this overall growth rate that we've been seeing in new confirmed cases. This equates to before March 15th, we saw about a 30% growth rate. Then after March 15th, it's not zero, but it's very small, 0.03. That's an equivalent of dropping the reproductive number that we're talking about before from 2.2 before March 15th to 1.1 after March 15th. And this is important in that, again, this 1.1 post March 15th is roughly what the pause scenario is continuing to track. So now I'm going to move into some results. What you're seeing here is 3 different curves. We've got confirmed cases on the left, hospitalizations and ventilations on the right. These are short-term projections. What you can see on this plot on the confirmed cases on the left is you see this wiggly black line. This is, again, the reported confirmed cases from VDH through Saturday. I don't think we were able to update this yesterday when we were pulling these slides together. Then you see this rainbow of colors coming out. The unmitigated is the gray. This green and orange combined is the slow. They track each other because we're looking zoomed in before we're considering any lifting at the moment. Then if you look at the bottom, this purple and pink that is tracking along this black line is the pause scenario. So this is, again, just the short term up until the 1st of May, just so you can get an appreciation zoomed in that we are indeed tracking this pause scenario. The key part of this model is then that we can also estimate hospitalizations. This is a reduction. So if you look at the y-axis, you'll see these numbers are much smaller. And if you actually measured it closely, you'll see there's also a time delay because from the time of confirmed case to hospitalization, there is a delay. And similarly with ventilation. Now, if we zoom back out, we're seeing a message of what these projections look like through the end of the summer. And so these futures depend on the policies and the actions that we take as a whole. These projections also, while we can calculate the peaks and we can look at these numbers, these are mathematical expressions of what might happen under these different conditions that we've set up. However, it is unknowable whether some other treatment, some other testing policies might come into place, other social distancing measures. Most of these peaks are all of these peaks are occurring after these measures have been lifted. So if we got to a point where we might be experiencing something like 10,000 cases in a single day, I think we would probably do something other than pretend that things are going back to a relative normal state. And so this pink line and purple line along the bottom shows, again, these pause scenarios that we're currently tracking. You can see these counts on the right. These are the median numbers of new confirmed cases in these projections. And you can see in the unmitigated, just as you can see in the picture, that you get to a really sharp peak in mid-May if we had continued to keep our foot on the pedal and accelerating out of control. And then you can see that these numbers drastically reduce even under the slowing growth, which is still growing, whereas under the pause, which we seem to be tracking, these numbers are even further smaller and reduced. We'll move on to the next slide. Why are these important? Again, we have too many cases in too short a time. We'll put demands on our healthcare system that it cannot meet without significant intervention. And so what we're trying to do is estimate when these capacities in the different regions of our Commonwealth might get exceeded for planning purposes. And so commonly, pandemic planners will assume that at any given time, 20% of the beds in a hospital could be used under normal conditions for treating folks from an acute outbreak or a pandemic. And then under emergency style conditions, they could even surge up to about 120% of the overall beds that they have. So you have this range from 80%, which is their steady state of capacity, to 120%, which is the surge capacity. So what you see here is the dotted line, the lower one is the standard 80% to 100%. So under normal conditions, what the number of COVID-19 cases that they could absorb. And then the dotted line, the dashed line along the top is under surge conditions, what they might be able to absorb. Again, capacities in a hospital are very hard to predict into the future. And so we're providing this purely as planning guidance. What we're looking at here again is the pause June 10th scenario. You can see that the Northern Virginia region would be the one that this projection shows would be exceeded first around mid-July. And again, that is about a full month following the lifting of the social distancing. So it's a projection, but it's not sure that we would actually follow this. You can see all the regions eventually do reach a point where their capacities do get exceeded. Table on the right shows you how this breaks down across the different regions. And so under the unmitigated, we would see that we'd start having problems in the coming weeks. We kept our foot on the pedal and accelerated out of control. We might already be beginning to feel it in a couple of weeks. Whereas under the pause June 10th, we're looking at mid-July when the first region might start exceeding, and then late August when the last starts to exceed. So I want to conclude with just sort of discussing what we're continuing to work on. We're incorporating age structure into the transmission dynamics, and that's going to have an important impact maybe on some of these outcomes. At the moment, we're using averages, but as we move into a finer grained look, I think it's going to be very important for us to include the age structure. And we've also not fully incorporated Virginia-specific outcomes and durations. We're again using national averages and estimates from the literature. Those will get better as we get more information in from a partnership with VDH. And we're going to look into the role of seasonality and incorporate it if warranted. The consensus seems to be that it may have some impact, but unfortunately is not going to be sufficient probably to change things dramatically for us, and it's still going to rely on our collective actions as a society. We're also going to look deeper into the test, trace, and isolation mitigations with other modeling style platforms. We hope to be able to share these projections on a more regular basis through a dashboard. Again, I want to just conclude with some of these key takeaways. Current social distancing efforts seem to be working. We do not need perfect projections to be able to draw these conclusions. We can still plan based on what these projections are showing. Under these current conditions, we do have sufficient medical resources to last for a couple of months. And it is dangerous to consider lifting these social distancings too soon or before we have other measures in place to help further dampen this outbreak. There's some references in the slide deck, and again, I just wanted to conclude with acknowledging we have a large team of folks on the COVID-19 response team at the Biocomplexity Institute. I'm merely their spokesperson. With that, I think I will conclude.
All right, thank you very much. This is Secretary Carey. Thank you, Chris, Madav, and Brian for a great presentation. And as you can see, these projections are indeed very complex. And we're grateful to be able to turn to some of our nation's leading data experts to help us make sense of where we go now. There is no one model that is going to tell us exactly what will happen, but we can use these models to form general conclusions that will help guide the governor in making policy decisions. The top three takeaways of this data are the following. One, social distancing is important and it's working in Virginia. Our actions right now and going forward will affect our outcomes. And we're also in it for the long haul, and we need Virginians to keep working with us on this. Two, right now, given the snapshot, we are optimistic about our hospital capacity. That being said, we are continuing to work with our hospital systems and a variety of other partners to make sure we have the space, equipment, and staffing that is needed and when it is needed. Third, it's clear we need to be responsible about how we ease these restrictions. Like every other state and many other countries right now, we are preparing for how we can move forward in a way that does not trigger a second or third medical surge. Now we'd like to open the floor to questions, and I realize that our time, and we'll take questions for at least 10 more minutes. We're able to change our schedules a bit. So with that, I'll turn to Elena, who I think has the questions for the panelists or for me.
Great. Thank you so much to the presenters, and thank you to everyone who submitted your questions to me. We're going to start with a question from Kate Masters with the Mercury, which is, why did the Virginia-specific model take longer to develop than the others, such as the one from the University of Washington? And what were the specific challenges or inputs that had to go into that? And this is for the UVA team.
Sure, I can take a stab at that. This model's been available, and we've been informing a variety of federal partners, ranging from the CDC and DoD for a number of weeks, tailoring it to the Virginia situation and their particular questions always takes gathering some more data. And the key part here is that we had to get to a point in the epidemic where we could observe what the effects of these social distancing measures were to be able to give reasonable projections like this. And it just takes time for us to gather that data and analyze it appropriately. We had to get to this point in the epidemic.
Thank you. And this next question is actually pretty related to that, which is from Max Thornberry. These are the models that Virginia is using. How different are they from the models used by federal officials? And I know you said that UVA has been working with some federal officials. If you could just explain a little bit about that.
Well, the federal government is obviously a broad swath. There's different agencies. We work primarily, we work with several different federal agencies. In every case that we work with them, to my knowledge, they use a number of different models, including input from us. Our primary connection to the federal government is through the Department of Defense. Our models are used there and have been used there for some time as different epidemiological questions have arisen over the years. So what I'm saying is that there are many models being used by the federal government, including ours, and it depends on the circumstances in the event which ones they're using.
Thank you. This is a question from Matthew with the Associated Press. The question is about seasonality. Why would seasonality only have a small impact? Haven't previous coronaviruses been seasonal? And are models able to account for seasonality in any way?
Sure, the seasonality question has been one that's been plaguing our community for a bit of time. And indeed, other coronaviruses do have a seasonal component to it. This is a novel coronavirus, not necessarily guaranteed. It's reasonably freshly crossed over from zoonotic sources, so not guaranteed to behave as the other human coronaviruses. The consensus is that we've seen some evidence that there may be some reductions related to the seasonality or changes in, not necessarily changes in the weather, but due to the weather in different locations. It's been hard to untangle whether that's the public health response, the societal changes, or just purely the weather itself. And because all those things come into play, it's very hard to tease out the exact amount that is due to the weather alone. I think the consensus amongst the group of modelers we've been working with for several months in response to this pandemic is that it will have an impact, probably a smallish impact, an impact that of the magnitude that alone drive this thing to extinction. However, most folks will not be surprised if we see things diminish a little bit, which might buy us another little bit of time as well, which I hope we can use.
Thank you. This question is from Mallory No Pain. She says, the range for infectious period you used was, this is directed to the University of Virginia, was 3.3 to 5 days. I thought the range was 14 days. If you could explain that, that would be great.
Yeah, that's a really, really important point. So what we're looking at in this transmission dynamic model and calibrating it is not the total period that one is infectious, but the total period that one is infectious and participating in disease transmission. So that 3 to 5 days is assuming that people get removed from the population and are no longer continuing to infect people as they get hospitalized. There are some nosocomial infections, but it is not significant in the transmission dynamics in the population at large. And so what we're really looking at is the period of time that this model is assuming a given infectious person can mix and create further infection. Before they might be isolated or confirmed positive and self-isolated home and maybe only infect a household member or be hospitalized. So that's the period. It's not necessarily biologically, indeed, it's a much longer period.
Thank you, Brian. This next question is from Bruce Potter, which I think is a good question. Do the projections on the June 10th pause scenario assume that after June 10th, things return to normal?
That's a great question, and one that I didn't have the time or forgot to mention as I was describing them. We are assuming after lift that things do not go back to complete normal, but sort of a halfway response. And what that basically means is that you would see an increase in the number of workplaces that might be opening, but it's not a complete 100%. Everyone's working like it was before March 15th.
Thank you. This is a question from Mel with the Richmond Times-Dispatch. Can you talk more about what UVA's projections tell us about Virginia's peak day in terms of cases? So she says, you say current data is tracking closest to a pause in the intensity. Assuming restrictions are lifted June 10th, when would we see a peak?
You broke up a little bit there, but I think it was coming to.
Sorry, assuming she's asking about the pause in intensity version of the model. Assuming restrictions are lifted on June 10th, when would we see a peak?
Right. So those projections were are shown in detail in these slides, and again, these peaks again are the sort of mathematical result of things returning, as I described earlier, sort of halfway to normal. So you do see these sharp growths on the pause June 10th. If we just do that and continue on our merry way, even though we see cases continue to grow and grow to very high numbers, the ultimate high number does occur around mid-August in the median. However, there's a wide range around that, depending on which set of the parameters we're tracking. That these clouds around the lines that I showed are the uncertainty bound. So that could range anywhere from mid-July all the way through September and possibly later. But again, these are just peaks that assume that we would take no further actions and there's no other measures in place. It just allows the mathematical equation to continue to march on.
Thank you. This is Elena, and with a related question, and I just want to make sure everyone got that last point, which is that, and please correct me if I'm wrong, which is that the models that show the June 10th model obviously assumes a lifting of restrictions on June 10th, which then, so any subsequent peak from there assumes that that fact. And am I correct, Brian, in saying that it also assumes an absence of other types of interventions like the ones we were talking about around testing, tracing, et cetera?
Yes, I think that's a good way. Maybe another way to frame it is that after things are lifted, we return halfway back to the way things were before March 15th. What half means exactly is difficult to fully describe, but in this current situation, we've got a lot of folks staying at home, not doing a lot. It's been a lot of fun on my end, working with the kids and everything. It's been nice. But that's sort of our post. And so the prior, everyone was going into the office and doing everything as normal, going to stores quite a lot. I think the Cuebiq mobility and the Google mobility reports that I cited give a good idea about what those reductions are. And so we'd expect to see those go back. And that is what's creating these sort of peaks following the lifting of these social distancing measures.
Alina, if I could add just a few words to what Brian said. We really think that the way we have shown the peaks are never going to happen in that form. People always adapt to the ground reality. So the peak should be just viewed as a mathematical possibility. But with our belief is that this is used to guide how the interventions are going to be put in place. We're constantly controlling the trajectory of this epidemic so that we never reach that peak. And that's the kind of policy decisions that would be taken as time progresses.
Thank you. This is from Gary with the pilot. It says the UVA model that we are tracking most closely means that eventually there comes a point where hospitals will be overwhelmed. Can you talk about what options, and this is for you, Secretary Carey, can you talk about what options are being considered to stop that from happening, or to further lengthen, for lack of a better word, the curves so that we do not go above hospital capacity?
Sure. We do have a number of policy options in order to recommend to the governor. And I think the key thing here is that there's this initial phase, and that was where we were initially most concerned, and we remain concerned. And we're following the actual trends of data in the hospital use, the ICU use, the ventilator use by region, and do we have the surge capacity to meet foreseen needs in this first bump? And then, as the UVA model indicates, we definitely need to have additional strategies. And whether that turns out to be complex testing of who is allowed to do what based on antibody tests, by thermography, that meaning temperature measurement going into workplaces. We will, and also there are applications that folks have used that contact trace in a sophisticated way and yields out a risk of transmission by individual. And how to do that in a complex open society like the US and in Virginia in a nuanced and responsible way. We've got to develop that, as does this country and every state. So those are some of the options. We definitely need to develop a different toolkit besides open everything up or open it halfway. We're going to have to figure out by recovery cases, by testing, and also by other interventions, and follow it. I mean, are there triggers, for example, when you've opened it up a certain amount, or you've encouraged folks to not necessarily use facial coverings at some point in the future? When would you restart that? When would you, again, there are a variety of tools, some of which frankly have not been developed yet, that we need to develop between June and July and August to make sure we do this in a nuanced way. So when the governor indicates how we're going to respond, it needs to be following these things. And again, the other thing of the model, and I think the researchers address this, is that you never let it get to those curves. It tells you if you don't make sure that you're following this and tracking this, that's as bad as it could be, but we're never going to let it get to that. And we're going to need to figure out together how we allow our businesses to open up, but also keep our residents safe. So we don't have this all figured out. There's not a toolkit developed yet at the federal level, but we are looking at what those tools are. I've mentioned some of them already. So I hope that answers your question.
Great. And we have time for about two more, and I'm going to ask them right now. And the last one is kind of a good one to wrap up on. So the first one is from Luann with the Roanoke Times. She said, can you explain whether more extensive testing and tracing could change the projections? And this might be a good question. Madhav, I see you nodding, or for Carter with Rand. And then after that, Secretary Carey, I'll turn it back to you for a final word addressing this question from Jake. BS6, which is how should the average Virginian who wants to head back to normal take in this data, maybe just sort of looking at the points that you made earlier. So let's start with the first one, which is extensive testing and tracing. How could this change the projections?
Carter, go ahead.
Yeah, so first off, how that would change the projections if barring any policy response, so hopefully you would do something with that information, but even if you weren't doing anything with that information, it would give us better estimates for the input values. So we would have a better estimate for how many people actually have it now and for the responses. And so there would be less uncertainty in the model, in these models, and hopefully you would get better numbers. Though hopefully there would be, you wouldn't just test, you would also do something with that information, segregate, self-isolation, that kind of stuff that would then impact the models. That would impact the behavior that would be captured by the models. And so it sort of depends on what you're assuming that additional policy response is. And I'll pass it on to UVA to respond.
Right, I'll be brief. As you test more, we all know that a lot of asymptomatic cases in the society. So you expect the numbers to go up simply because you're testing more. But as Carter has said, and Brian said it earlier, you use that information to guide the model development. The number 7 that Brian mentioned, for instance, is based on the assumption that for every person that you have a confirmed case for, you have 7 people who are not showing up. And as you test more, you get a better handle on that particular assumption that you make. You, of course, have a better chance to control the disease through contact tracing and testing as well, so that you can place interventions early on and stop the spread.
If I might add, this dovetails into the other question about what the average Virginian that wants to get back to normal would do. I don't have specific guidance for the average Virginian, but I can say that as this information becomes better understood, how many people have actually had and recovered from this disease and display immunity, for example, as we better understand the dynamics of how these successions of actions will take us forward, it'll be more and more possible to understand what you can do and expect not to reignite this disease in the population. As it stands, I think the average Virginian really needs to listen to the guidance of the state officials and try to do what they're asked to do because it's working.
And thank you. And I'll bring this to a close. Thank you to our panelists, our experts, and thank you for our own ongoing interaction. The question for me was that last question was, well, what are the takeaways that we think the average Virginian should take from this discussion? And I think first is that something the governor has emphasized again and again, that we are in this together.